really are a function of a woman's age. And we're going to skip these. We're going to take a look at some congenital anomalies in the breast. Here's a common anomaly we see in the breast. This is congenital inversion of the nipple. The very tip of the nipple is inverted. This is called congenital inversion of the nipple. It's usually caused by some sort of lactiferous duct that's short, or some sort of fibrous tissue that's pulling on the very tip of the nipple. The biggest problems with this congenital inversion is really aesthetic. Sometimes a woman does not like the appearance of this inverted nipple and would want to do something about it. Other complications, potentially there's a problem with breastfeeding. There is a procedure to correct this problem. The procedure involves cutting through the base of the nipple and cutting through any tissue that's causing the retraction. We then suture the nipple in an everted position, and it'll heal in that position. The problem with that procedure is it leaves the nipple unuseful. It interferes with the functioning of the nipple, and so after that procedure, it may correct the aesthetics, but the nipple will lose its functionality. The breast loses its functionality. Next thing we want to take a look at is a galactocele. A galactocele is a dilated segment of lactiferous ducts. This is something that usually develops in older woman who is breastfeeding, usually a woman who's in excess of 40 years old. Sometimes what happens is that the woman's secretions will become inspissated and form concretions or occlusions in the lactiferous ducts. So take a look at that. Here we have a diagram of the breast. Again, you can see lots of tissue here. They've got the glands over here. The glands are producing lactiferous secretions. They're going to go through the ducts, then through the lactiferous sinuses, and of course out the nipple here. Sometimes what happens, particularly when the woman gets dehydrated, some of these secretions will become inspissated and obstruct a part or all of the duct. If that happens, pressure is going to build up behind the occlusion and cause a segment of duct to become focally dilated. That's what we call a galactocele. The problem with the galactocele, sometimes it will rupture, spilling the contents into the surrounding tissue of the breast. That will result in a periductal mastitis, inflammation of the breast. A woman will feel that as some focal area of tenderness, and possibly an area of induration, meaning it's very firm. And again, that might have her concerned. There is, of course, no concern if it is indeed a ruptured galactocele. To try to correct the problem, we keep the woman hydrated, we can apply some heat to the area, and that should accelerate the resolution of the problem. Any questions on that? Next, we want to talk about fibrocystic disease, fibrocystic changes. Again, this is another condition that has multiple names, the most common of which is, by today's standard, fibrocystic changes. It's a condition where the breast becomes fibrotic and cystic. The breast accumulates a lot of fibrous tissue, and some of the lactiferous ducts become cystically dilated. And this generally will present with a lot of irregular texture to the breast. The breast will feel very irregular, a lot of lumpy, bumpy feeling in the breast. And again, this is just due to the development of these cysts and lots of scar tissue. And let's take a look at the radiographic appearance of fibrocystic disease. You can appreciate the extent of the disease. Let's first take a look at the normal mammogram. This is type of xerographic mammogram. And again, typically in a mammogram, we want to put the image of the right breast right next to the image of the left breast. We do that so we can scan through the image for symmetry. This happens to be a xerographic mammogram, which all the grayscale is inverted. The lighter areas are radiolucent, whereas the darker areas are now radiodense. Again, you can tell this is a postmenopausal breast. There's a nipple here, nipples about there. You can see the convergence of lots of lactiferous ducts and sinuses on the nipple here and here. You look through this breast, everything looks good. You'll notice that there are some radiographic densities scattered throughout the breast. These radiographic densities are actually benign calcifications. They are typically areas of the breast which have undergone degenerative changes. Typically what happens is that the fatty adipose tissue in part of the breast sometimes will degenerate as a result of trauma, releasing free fatty acids. These free fatty acids will accumulate calcium and form calcium fatty acid salts. And of course, they form these little concretions we call calcifications. These are also what we call benign calcifications. They're just calcified areas of breast that have undergone dystrophic degenerative changes. Okay. It's very common to see these types of benign calcifications in older breasts. Again, older breast has a higher proportion of adipose tissue. It's more likely that that adipose tissue will be damaged in some way when a woman gets older. Sometimes we see adipose degenerative changes in a woman's breast because of trauma. Maybe she was in a car accident or something. Sometimes it might be an animal bite, a dog bite, or something like that. We see these types of degenerative changes resulting in calcification. They look fairly isolated, round, and well circumscribed, and so in all appearances, they look like what we call benign calcifications. Nothing related to malignancy at all. This is what a normal breast looks like. Here's what fibrocystic disease would look like in a xerographic mammogram. Again, we have the image of the right and left breast side by side. And you can appreciate that there is lots of irregularity in the radiodensity of this breast. Again, that's caused by differences in scarring and lots of ducts becoming cystically dilated. A woman will feel this as an irregular texture, and again, she may feel lumps and bumps in the breast. And that actually may bring her to her general practitioner, and she may be concerned about these lumps and bumps. If this is truly fibrocystic disease, and it is isolated to just scarring and cystic dilation, then there's nothing to worry about. There's not even an increase in the risk of developing any kind of breast cancer. Let's take a look at the tissues remarkable for fibrocystic disease. Here we have the product of a multiple lumpectomy. We've taken out lumps in the breast, and we can see some different tissue types. And we take a look at this specimen. This specimen tends to represent proportions of different tissues we expect to find in the breast of a woman approaching the age of 40. You can see we've got some glandular tissue here, we've got some fatty tissue there, and we got some fibrous tissue here. We got a nice proportion of different tissues. This specimen would generally be representative of what normal breast tissue would look like. Okay. Down here, however, we have a specimen that's representative of fibrocystic changes. You can see the composition of this lump, this sample of tissue is very different. There is some adipose tissue, very little glandular tissue, but a whole lot of fibrous tissue. And in this fibrous tissue, you see a cyst. This is a dilated duct. Okay. This is what fibrocystic disease would look like grossly. Lots of fibrous tissue and lots of dilated ducts. And of course, this is going to make the breast feel very irregular. And again, the woman may be concerned. She may feel this as a lump and bring it to the attention of her general practitioner. Again, if this is truly fibrocystic disease, there's nothing to worry about. There's no increase in the risk of cancer of the breast of any kind. Okay. Now, in reality, there are two components to fibrocystic disease, one of which I just showed you. It's just fibrosis and cyst formation. Fibrosis and cyst formation is a component of fibrocystic disease we generally refer to as non-proliferative component, the non-proliferative component of fibrocystic disease. In most cases of fibrocystic disease, this is all you see, fibrous tissue and ductal dilation forming cysts. Sometimes, however, there is a second component. It's called the proliferative component. The proliferative component in turn consists of two subcomponents, epithelial hyperplasia and sclerosing adenosis. And let's take a look at epithelial hyperplasia. Epithelial hyperplasia refers to a condition where the epithelium of the duct tends to overproliferate. Let's take a look at this. Here's a section through a lactating breast showing you the normal ductal epithelium. Okay, you can see lots of ducts in here filled with lactiferous secretions. And you can see the structure of the duct here. Again, generally you have two layers of cells. There is the epithelium, and then there's a myoepithelium that contracts, propels lactiferous secretions. You can see that the wall of the duct is relatively thin, and again, the ducts here are filled with secretions. You got nice patent lumen, everything looks good. This is what a normal duct looks like. This is what epithelial hyperplasia would look like. Again, you can see a single duct here, and you'll notice that the epithelium of the duct is overproliferating, so much so it's beginning to block the lumen of the lactiferous duct. In fact, the only thing you have left here is a couple of cannulae here. This is sometimes referred to as a fenestrated pattern, and you've got little patencies here, the cannula. Every other part of the duct is kind of blocked by an overproliferation of epithelial cells. This is called epithelial hyperplasia. It's sometimes an additional component of change that we see in fibrocystic change, this type of proliferative change that we sometimes see in fibrocystic disease. Another component of proliferative change that we sometimes see in fibrocystic disease is called sclerosing adenosis. This is a strange condition where the glandular tissue of the breast overproliferates and starts infiltrating the remainder of the breast, causing lots of scarring. This is not a neoplastic process. It is simply a process in which the cells of the glands become hyperplastic. Again, proliferate, they kind of spread out in the breast, triggering this kind of scarring reaction. The growth of the glands is referred to as adenosis, and the scarring is referred to as sclerosing. So the condition is called sclerosing adenosis, a condition where the breast scars down due to the proliferation of glands. Here's a section through sclerosing adenosis. First glance, you see all these little glandular structures. My God, it looks like adenocarcinoma. This all looks like adenocarcinoma with a lot of glands infiltrating the tissue. But if you examine the epithelial cells of the gland, you'll notice they're all normal looking. There are two layers. There's a epithelial layer, there's outer myoepithelial layer. The architecture of the glands is normal, and the cell architecture is normal. It's just that the glands are overproliferating, and again, they're infiltrating the breast, causing the scarring reaction. And so we don't call it an adenocarcinoma. It's not a cancer. It's not even a neoplasm. It is just a proliferation of glands. We call it adenosis, and it's causing scarring, so we call it sclerosing adenosis. Again, this is another change we might see in fibrocystic disease of the breast. So fibrocystic disease of the breast consists of two components. We've got the non-proliferative component, which is scarring and ductal dilation. And then sometimes that's accompanied by the proliferative component, where we could see sclerosing adenosis as well as epithelial hyperplasia. Now, ultimately, a woman's going to want to know what her risk for developing cancer is having this condition of fibrocystic disease. Well, it really depends on what components are present. Remember, we have a non-proliferative component, we have a proliferative component. Most of the time, people just have this non-proliferative component. You've got scarring, and you've got this ductal dilation. If that's the only component present, the non-proliferative component is the only component present, then her risk for developing cancer of the breast is no greater than a control subject who does not have this condition. And there's no increase in the risk for her developing breast cancer. However, if she has the proliferative component, any proliferative component of fibrocystic disease, then there is a measurable increase in the risk of breast cancer. Exactly what that risk is depends on what components of the proliferative aspect of the disease is present. If she has simply sclerosing adenosis, well, she has an increase in the risk of developing cancer that's 1.5-fold over control subjects who have no disease at all. So she has a slight increase in the risk of developing breast cancer. The real risk comes when she has these hyperplasias, sometimes with atypia, sometimes without atypia. Now, if she has epithelial hyperplasia without atypia, meaning that the epithelial cells of the glands are proliferating, but they don't look funny. They don't look like they're poorly differentiated. They don't look like they're mutating into something. Then her risk for developing breast cancer is 2-fold over a control subject that has no disease. The big risk is when she has epithelial hyperplasia with atypia, meaning that the cells of the glands are very atypical looking. They're starting to lose differentiation. They're crowding each other. If she has epithelial hyperplasia with atypia, excuse me, her chance for developing cancer of the breast is 5-fold over a control subject who does not have any disease at all. Okay, so there's a significant increase in development of probability of developing cancer if she has epithelial hyperplasia with atypia. Now, all of these risk factors can be compounded if the woman has a family history of breast cancer, a significant family history of breast cancer, meaning that perhaps her mother or some close relative developed breast cancer prior to the age of 55. That's a significant family history of breast cancer. If that's the case, then all of these probabilities of developing cancer will be compounded with that family history. And when you have, for example, a woman with epithelial hyperplasia with atypia plus a family history, maybe her chances of developing breast cancer could be 10-fold over a control subject, in which case the woman might want to consider a prophylactic mastectomy. She may actually consider having the breast removed to avoid the possibility of developing breast cancer. That may be an option she would want to consider. Any questions on that? Yes.
Just to clarify, so if the patient has a cyst, you don't have an increase.
There's no increase in the risk of breast cancer. If she has any of the non-proliferative components of fibrocystic disease, that's her risk over control. No greater than a control subject. Okay, that's the best, that's the worst. Any questions on that? Okay. That's the case. Let's take a look at infectious mastitis. Inflammation of the breast caused by an infection. We call that infectious mastitis. Usually, this is something that develops during a period when the mother is nursing a child. And sometimes what happens is during nursing, some bacteria, particularly staph and strep, can gain access to the breast through the lactiferous ducts and infect the breast tissue, inciting inflammation. This is what we call an infectious mastitis. Now, the most common agents are streptococcus and staphylococcus. An infection of staph and strep generally present differently. For example, an infection with streptococcus usually is an infection in which there's a diffuse inflammation of the breast. The entire breast becomes inflamed. A lot of tenderness, a lot of erythema, a lot of calor. A staphylococcus infection presents generally differently. It's usually localized and presents abscesses. Staphylococcus is very pyogenic, meaning it forms pus, it forms abscesses. And so an infection with Staphylococcus aureus usually will present with a very localized infection, which is abscessed. Usually, the treatment is the same for either infectious agent. You can treat staph and strep with dicloxacillin. That's effective against both organisms. If there is an abscess present, then that, of course, will have to be drained. Usually, incision and drainage will be required to resolve an abscess. Any questions on infectious mastitis? Okay, traumatic fat necrosis. I mentioned this before, that as a woman increases in age, again, a greater proportion of her breast is going to be composed of adipose tissue. That adipose tissue is subject to trauma and damage and can degenerate. When it degenerates, it releases free fatty acids, all of which have a negative charge. That negative charge will attract a positively charged cation, specifically calcium. Calcium fatty acid salts will then form, and a calcified concretion will take the place of the damaged adipose tissue. Okay, generally, we see this in traumatic events, some sort of trauma to the breast, older breast. Again, maybe a vehicular accident occurs, maybe there's a dog bite or something like that. Those are typically the different types of trauma that we see in the breast that can lead to degenerative changes in the adipose tissue with subsequent dystrophic calcification. Let's take a look at that. Here's an example of normal breast. Again, you can see lots of ducts in here. This is an example of fat degenerative changes in the breast, fat necrosis. You can see we've got a breast here that's infiltrated with a lot of inflammatory cells. Okay, there's some frank necrosis here, and you see these. These are anhydrous droplets of lipid. These anhydrous droplets of lipid are going to attract a lot of calcium, and subsequently, this area, probably the whole area of the breast, will calcify. The calcification generally be very kind of isolated, very well circumscribed. The calcification will be consistent with some benign type of presentation, a benign condition. And so we call them benign calcifications because they're just caused by trauma. There are some types of calcifications that develop in the breast that are associated with malignancies, but they present very differently. Calcifications usually are little micro-sized calcifications, about the size of a grain of sand, and they tend to cluster. Clustering microscopic calcifications, that's consistent with a malignant process. This type of calcification we see in trauma to the breast generally forms these very large, very round, well circumscribed clumps of calcium. That's consistent with a benign process, and so we call them benign calcifications. Any questions on that? Again, you tend to see them in older breasts rather than younger breasts. Well, let's take a look at some tumors of the breast. First thing we'll start with is fibroadenoma. This is the most common benign neoplasm of the breast, fibroadenoma. As its name suggests, it is an overproliferation of fibrous tissue and glandular tissue. It's benign, it's a benign proliferation, and it generally presents in a benign way. Okay? Very well circumscribed and mobile. Let's take a look. Here's an example of a mammogram of a woman with multiple fibroadenomas. Okay, you can see again, there's the left breast, this is the right breast. Images of the breast are put side by side again, so you can kind of look at the symmetry of the breast. You'll notice that there are these very well circumscribed masses in the breast, one here, there's one down here. These are fibroadenomas. Just looking at them based on radiograph, it seems that they're benign. Again, they have this very smooth contour, very well circumscribed contour. That's consistent with a fibroadenoma. Okay. Fibroadenomas, again, the most common type of benign neoplasm. Peak incidence for fibroadenomas will be around the age of 30. They are estrogen dependent, meaning that they tend to grow and involute along with a woman's cycle. The estrogen levels increase and decrease. And estrogen levels increase, they tend to get a little larger. Estrogen levels decrease, they tend to shrink a little. Postmenopausally, these fibroadenomas will tend to involute to the point where they calcify. And then again, you'll have these very large, benign-looking calcifications in the breast. Let's take a look at the gross appearance of fibroadenoma. Okay, here's a section through the breast. This breast that also happen to have fibrocystic disease. Okay. This is an example of some tissue of the breast, which is remarkable for fibrocystic disease. A lot of fibrous tissue, very little adipose tissue and glandular tissue. Over to the right here, you can see this very well circumscribed, very smooth contoured lump. That's a fibroadenoma. Fibroadenoma consists of an overproliferation of fibrous tissue and glandular tissue. Take a section right there. Okay, here you can see the fibroadenoma here. Here's some normal breast tissue, and in between you can see a pseudocapsule. Take a look at the fibroadenoma. You can see the proliferation of stroma and glandular tissue here. Okay, that's the fibro. And there's the adenomatous component, fibroadenoma. And the most common age for this to develop is around the age of 30. They don't represent any kind of malignant degenerative potential. It's not known that fibroadenomas undergo malignant degenerative changes. A woman will present with a lump. She will be able to feel the lump. It'll be well circumscribed. It'll be mobile. You'll be able to move it around because it will not locally invade and anchor itself into position. So it'll be well circumscribed, well delimited, and mobile. And that is consistent, of course, with benignancy. Now, if a woman's presenting with a lump like this for the first time, you really do have to make sure it is indeed a fibroadenoma and it is indeed benign. Now, you can make a lot of correlations. You can take a mammogram and, yeah, it looks like it's very smooth and all of that. Looks like it's isolated, looks like it's well circumscribed, well delimited, etc. Those are fine. Those are all consistent with malignancy. But in a case where a woman is presenting for the first time with an isolated lump like this, that's probably a neoplasm, you have to make sure it's benign. And so typically, the first time a woman presents with a lump, we have to do an excisional biopsy. We have to go in and remove the tumor and just verify that it is indeed benign. We can't simply rely on a physical exam. We can't simply rely on a mammogram. We have to absolutely verify that it is benign. There have been instances where people have gotten in trouble because it looks benign on physical exam, it looks benign on radiograph, but then turned out to be a malignancy that was just masquerading as a benignancy. And so we have to be very careful with some of these and perform a excisional biopsy. Once we establish that the woman is prone to develop fibroadenomas, if she presents with another lump, it may not be necessary to perform an excisional biopsy. We have some sort of precedent, yet yes, this woman is forming fibroadenomas. Any questions on that? Okay. Let's take a look at cancers. Okay, this is the second highest cause of death in women. Cancer-related deaths is breast cancer. Remember, the number one cause of cancer-related death in women is lung cancer due to cigarette smoking. When a breast cancer develops, about half of them develop in the upper outer quadrant of the breast. So there's actually 1/4 of the breast, in which 50% of the malignancies tend to develop. About 90% of these malignancies will arise from the ductal epithelium, from the ducts. And the remainder tends to develop in the lobular, the glandular epithelium. Okay, a couple of risk factors, highest in North America. Age is a risk factor, and the risk will increase until menopause. And that is because when a woman is cycling, these cells in the breast grow and involute along with the woman's cycle. And you know that when they do that, they're going to have to replicate their DNA. They do some making mistakes. Some of the mistakes are not corrected, and they persist as mutations. So the more cycles the woman is exposed to, the greater the chance of developing mutations that are significant. And so the risk for developing breast cancer increases as a function of a woman's age up to the point where she goes through menopause and stops cycling. Okay, certain genetics, very important ones you probably heard about, the P53 gene, which again is this major cancer suppressor gene, but there are some bronchogenes, the BRCA gene, the breast cancer genes, breast cancer gene 1, breast cancer gene 2. Okay, those all encode for tumor suppressor genes. If there is a deactivating defect in any one of those cancer suppressor genes, then the risk for developing breast cancer increases multifold. A prolonged exposure to endogenous estrogens. Again, the more she cycles, the more risk she carries. The earlier the onset of menarche, the later the onset of menopause, the greater the risk. And that's because she's cycling more. She's putting these cells through more cycles. Any kind of pre-existing problem, like, for example, epithelial hyperplasia, as in the proliferative component of fibrocystic disease, you have some pre-existing condition like that, that can increase the risk factor 5-fold. If she's taking exogenous estrogens, like estrogen supplement, that can increase the risk of breast cancer. It is known that contraceptives, particularly combo pills, can decrease the risk for endometrial carcinoma. Progesterone does not. It's also known that progesterone only does not increase the risk for breast cancer. So If someone's going to take a contraceptive, perhaps progesterone is the better one to take. It stops the woman, prevents the woman from cycling, at least in this aspect. If she stops cycling again, there's a chance it'll decrease the risk in developing breast cancer. Other things, alcohol, obesity. Obesity is usually a hyperestrogenic state. Again, the breast can be overstimulated. Cigarette smoking and a high-fat diet also known to be linked to breast cancer. Okay. Now, we said that most of the cancers can develop in the ducts. It's going to start off as a dysplastic lesion, and that dysplasia could degenerate to a locally invasive cancer. So let's take a look and begin examining the different types of dysplasias that can develop in the ducts and the glands, beginning with the intraductal carcinoma in situ. Let's take a look at this. Let's first understand that most of the cancers develop in the upper outer quadrant. Clinically, you remember we divide the breast into 4 quadrants. You've got the inner quadrants, we've got the outer quadrants. Most of the cancers that are going to develop in this quadrant right here, the upper outer quadrant, which includes the tail of Spence. If you're going to examine the breast for lumps and bumps, this is where you're going to get 50% of them right here. So this would be a high yield area to examine the breast. Now, all these different cancers develop as a dysplastic lesion. Start off with a dysplastic lesion. A dysplastic lesion is benign by definition, but it can degenerate to a locally invasive cancer. Let's take a look at a ductal dysplasia. So many of the cancers develop from ductal dysplasia. Here's an example of a ductal dysplasia beginning to develop into a cancer. We have a duct right here, okay? And you can see immediately there's something wrong with this duct. The epithelium is overgrown, okay? Extensively overgrown. You have this fenestrated architecture or cribiform architecture in which there are only these small little cannulae present to conduct any kind of lactiferous secretions through the ducts. Every other part of the duct is blocked by these overgrown cells. These overgrown cells are very atypical looking. Now you can see that most of the cells are respecting the basement membrane that encapsulates this duct. Okay, they're respecting the basement membrane. If that were the case, this would be just a dysplastic lesion. Again, it's a lesion where dysplasia is nothing more than just a kind of loss of proliferative control of these cells, where they're overgrowing out of control. That's clearly a neoplasm, but if they respect the basement membrane, it may be a neoplasm, but it's not a cancer. Okay, and these cells, at least over here, seem to be respecting the basement membrane. If that were the case for the entire specimen, then this would be just a dysplastic lesion. However, you can see where cells have broken through the basement membrane over here and here. And when you see something like that, that's called local invasion. And local invasion is a defining feature of cancer. So this is an example of a ductal carcinoma in situ, a dysplastic lesion progressing to cancer right before your eyes, right there. It's just beginning to develop. And this is how these cancers progress. They start off as a dysplastic lesion in which cells are overproliferating, but they're still contained by a natural tissue boundary like the basement membrane. And then finally, they mutate, they break through the basement membrane, that's local invasion, they develop into cancer. Same thing happens with lobular carcinoma in situ. Lobular carcinoma in situ is a dysplastic lesion that develops in the glands. Something very similar happens. You start off as a dysplastic lesion. The cells respect the basement membrane, but they're overproliferating. It's a true neoplasm, but a benign one. And it'll remain benign until they break through the basement membrane that keeps them confined to the glands, and then they start infiltrating the breast. And that's when a lobular carcinoma in situ develops into a lobular cancer. Okay, let's have a look at this. These cancers. Let's first take a look at a ductal carcinoma, a cancer that develops from a ductal dysplastic lesion. Okay, here's normal breast, just standard mammogram, nipples here. Again, you can tell, what do you think? This is a post or premenopausal breast? Post or premenopausal? That's a postmenopausal breast. And you can see how lucent it is. You can actually see blood vessels. Again, lactiferous ducts here converging on the nipple. That is a postmenopausal breast, most likely. Okay. Everything looks okay here in the radiograph. Here's what a ductal carcinoma would look like, okay? You can spot it easily in a background of lucency. There's the nipple, there's the mass. You can see it's very irregular, has lots of irregular borders, very irregularly shaped. You've got these little areas of infiltration all over the place. Those areas of infiltration will anchor the mass to the pectoralis muscle, and you won't be able to get your fingers around it. You won't be able to move it. And so what you'll feel is a very irregular mass, poorly circumscribed, and you won't be able to move it under your fingers. Take a look at the mass. Okay, here it is, the product of lumpectomy. Well, the cancer's here, but where does it end and where does it begin? Okay, very difficult to tell. That's because of the local infiltration here. The borders are completely blurry. And that's why if you try to feel this mass, it'll feel very irregular. There'll be no clear boundaries at all. And as these cancer kind of infiltrates and spread out, eventually it'll dig into the pectoralis muscle, after which time you won't be able to move it. You won't be able to get your fingers around it. Taking a section through the cancer, this is what it looks like. Okay. Here's the ductal carcinoma right here. And here's some normal tissue right here. Got a lot of adipose tissue here in the breast. This is an older breast. Okay. There's the advancing cancer. Okay, you can see this cancer consists of lots of little glands. This is an adenocarcinoma. That's a ductal carcinoma. It's an adenocarcinoma. Okay, it's infiltrating. If you look at the boundary, it's not well circumscribed. There's no pseudocapsule. There's no nothing here to separate the diseased tissue from the normal tissue. And that's why these things are not well circumscribed at all. Their borders are very blurry. There's nothing to separate the normal tissue from the cancerous tissue. And so the boundaries are very blurry, very irregular. Now, again, these cancers do tend to infiltrate surrounding tissues, including the pectoralis muscle. Here are some of the presenting features of a breast cancer due to local invasion. Okay, here's some depictions. Here we have a depiction of a cancer of the breast. Okay, it's probably ductal carcinoma. The cancer tends to infiltrate the pectoralis muscle. Once it invades the pectoralis muscle, you're not getting your fingers around that. You're not even going to be able to move it. It's going to be anchored in position. Also, there's a tendency for this cancer to extend and invade the skin. And when it does, it tends to pull down on the skin, causing skin dimpling. Sometimes skin dimpling is a presenting feature as well. Also, sometimes you have the mass growing behind the nipple. It'll do the same thing. Sometimes the cancer will send out little extensions, grab hold of the nipple, and retract the nipple. The entire nipple will be pulled inward. That's called nipple retraction. Not to be confused with congenital inversion of the nipple. Let's take a look at that. Here's an example of nipple retraction, and you can see the nipple here. It's pulled right into the breast. Not just the tip of the nipple, the whole nipple is pulled into the breast. And that distinguishes it from congenital inversion of the nipple. Here's congenital inversion of the nipple, where just the tip of the nipple is inverted. And here's nipple retraction, where the whole nipple is retracted inward. Any questions on that? Okay, let's talk a minute about Paget's disease in the breast. And we looked at ductal carcinoma. Just showed you a couple examples of ductal carcinoma. Remember, it starts off as a dysplastic lesion of the duct that degenerates into a malignant ductal carcinoma. Usually the ductal carcinoma breaks through the basement membrane, invades all of the breast tissue. No question, it's invasive, it's cancer. Sometimes though, the ductal carcinoma doesn't quite learn to break through the basement membrane that keeps it contained in the duct. If that's the case, it tends to grow along the length of the duct until it actually comes out the nipple. When it comes out the nipple, it starts invading into the dermis. Now it's invading, it's truly a cancer, but it's not a very smart cancer. It hasn't learned to break through basement membranes. It just learned to infiltrate adipose tissue. When a ductal carcinoma begins to invade, but doesn't learn how to invade a basement membrane, just learns to invade the skin, we call this condition Paget's disease of the breast. Paget's disease of the breast presents in a very interesting way. Paget's disease of the breast is a type of ductal carcinoma that hasn't learned to break through the basement membrane. What it does is starts growing along the length of the duct, eventually comes out the nipple, and then starts invading the surrounding dermis. And it presents this way. Here's an example of a Paget's disease of the breast. There's the nipple right there. And you can see that there's this erythematous patch of skin here with scales on it. Very irregular boundaries, okay? Kind of notched boundaries, not necessarily very sharp boundaries. That's Paget's disease of the breast. It's a type of ductal carcinoma that doesn't quite learn to break through basement membranes, but learns to invade epidermis. There's a section through it, section through the skin. There's the epidermis. There's the dermis. There's a dermal epidermal basement membrane that runs right through there. If you look in the epidermis, you see these funny looking cells here. These are Paget cells. These are the cancer cells. Now, they truly are invading the epidermis, but they haven't learned to break through basement membrane. So this basement membrane here, the dermal epidermal junction, isn't breached, but the cancer cells are invading through the entire epidermis. So it's a type of kind of not so smart cancer, but it does show a local invasion, and therefore, by definition, is the cancer. Okay, that's Paget's disease of the breast. It's an intraductal cancer that infiltrates the skin. Okay. Any questions on that? Lobular cancer evolves a very similar way. It starts off as a dysplastic lesion of the glands. That dysplasia will develop into a locally invasive lobular cancer. Lobular cancer has a very interesting histologic presentation. When it begins to invade, it shows a characteristic way of spreading called Indian filing. There's a section through lobular cancer. You can see the cancer cells here. Notice how the cancer cells are lining up in a single file. That's referred to as Indian filing. Indian filing is characteristic of lobular cancer. Okay, now, eventually, these cancers do tend to metastasize to the regional lymph nodes. And when they do that, they block the regional lymph nodes, and they can cause lymphedema. Lymphedema presents with peau d'orange, a series of dystrophic changes of the skin that makes the skin look like the skin of an orange. This is what peau d'orange looks like. This is a Caucasian breast. You can see the nipple here, and you can see this orange discoloration of the skin. And you'll notice that around the hair follicles, you've got this implant. That's peau d'orange. That's a form of lymphedema. Okay, it's caused by the cancer metastasizing to the regional lymph nodes, causing obstruction. And that results in lymphedema. Okay, I'm not going to go on any further and jam things in. I just want to get to this point. Any questions? Okay, so this is the last of new material on the exam. Tomorrow we'll start going over questions. Any questions about what's on the exam?